welcome all of you to our 23rd live webinar on orthopedic principles. This time we have Professor Stephen Tower as distinguished faculty from Anchorage, Alaska. Dr. Stephen Tower has practiced general orthopedics and arthroprosthetic surgery in Anchorage, Alaska since 1992. He graduated from the University of Washington, University of Alaska School of Medicine in 1983, and completed orthopedic surgery residency at Oregon Health Sciences in 1992 after a prior career as General Medical Officer in the Indian Health Service Alaska Division. He's an affiliated professor of medicine at the University of Alaska's Anchorage Family Medical School campus and has a research interest in the failure modes of total hip arthroplasty and the epidemiology of trauma and orthopedic conditions in Alaska, United States. Dr. Tower is considered the foremost authority on Cobaltism related to metal-on-metal implants. He has researched and lectured extensively on this subject, and most of his work are quoted in high-impact journals. Over to you, Professor Stephen Tower. You can start your presentation. Thank you very much for joining in.
Thank you, Professor, and I greatly appreciate this opportunity to participate. I congratulate you on a impactful and unique program, and I need to tune into your sessions in the future to learn something. This presentation is a result of personal experience with metal-on-metal hip replacement gone awry starting in 2006. And I just kind of stumbled on this issue as a patient that particularly in the setting of a malfunctioning, not optimally positioned metal-on-metal hip with extraordinarily high levels of blood and urine cobalt, I personally experienced significant neurologic toxicity with a presentation at the time was thought to be primarily psychiatric, which, as you might imagine, having at the time been in practice for about 15 years was of significant concern to myself and my family. So this is kind of a saga, almost an odyssey of a greater than, I guess, close to a 15-year experience now. Not only was stumbling over something that wasn't widely appreciated, but also with the difficulties of getting the rest of the world to believe that I had stumbled on something that was not widely understood or described. This title slide was from public testimony I gave before the FDA in Washington, D.C., November 13th of last year. It was not my first experience with the FDA. I had been lobbying the FDA extensively since my first publication on the topic in 2010, and on multiple occasions had failed to communicate with the FDA that Cobaltism was not only an entity, but likely a common entity. And they steadfastly refused to recognize me as an expert on multiple occasions. And it all kind of came to a head last November when they denied me a position on their expert panel addressing the very subject which I was actually had personally described and had academic primacy on. And having been excluded from participating on the panel as an expert, I felt obligated to travel to Washington, D.C. and testify publicly. And they generously gave me 8.5 minutes to describe what had taken me more than a decade and thousands of hours of research to learn. At the time, I had my DePuy ASR total hip done in May of 2006. I was already somewhat of an academic authority in joint replacement. At that time, I had published the most extensive paper review on the treatment of periprosthetic femoral fractures when I was a resident in Oregon Health Sciences, which had won the Neufeld Award at the Western Orthopaedic meeting around 1992. And just before I elected to have my ASR metal on metal hip done, I had presented a paper at the American Academy of Orthopedic Surgery on catastrophic failures of longevity Zimmer crosslink polyethylene liners, which later got published in Journal of Bone and Joint and was the first case series of 4 failed liners in 2 somewhat petite from a bone structure perspective, but somewhat overweight women that each failed their Zimmer liners catastrophically within a couple of years. And they each failed 2 liners, a primary liner and a revision liner. And that was, there'd been one other publication of catastrophic failure of cross-link liners, but I think that particular publication of a series of liners was the first series published. It was published in Journal of Bone and Joint, and it did stimulate extensive revision of the design of the cross-link liners throughout industry, with people realizing that you can't make that material too thin, particularly at the rim, without risking a catastrophic rim cracking event, which usually leads to instability of the hip and premature revision. I have an unusual background because I had initial training in internal medicine and 4 years of experience in our public health service as a commissioned officer before I entered orthopedic residency, and had a lot of surgical experience going into orthopedic surgery, which gave me time to do, I think some reasonable research and pursue my interest in arthroprosthetics. After residency training, I came into private practice in Anchorage, Alaska. The beauty of private practice in Anchorage, Alaska is it's well removed from the rest of the United States. Although our population was fairly small, less than 1/2 the hospital I've worked with since I started serves as a tertiary referral center for the rest of the state. And given that Seattle is 2,500 miles away, about a 3 or 4 hour jet ride, it gave me a great carte blanche to do a wide-ranging tertiary practice in arthroprosthetics, revision arthroprosthetics, pediatrics, and trauma work, including Ilizarov over my career, which is just a unique opportunity, and really a product of being in a relatively isolated state at a tertiary center. I certainly have never been a high-volume surgeon, and I don't think I push the indications for surgery per se. I've never been widely economically successful as an orthopedic surgeon, but certainly have done very comfortably and been very appreciative of ability to return to the state of Alaska where I was born and practice orthopedics and enjoy the outdoors. But my situation in 2006, hot on the experience of knowing that there were design flaws in crosslink polyethylene, particularly if you push the head size and the poly was too thin, and having attended a lot of meetings where everybody was singing the praises of hip resurfacing and metal on metal as being a potential solution to allow a relatively anatomically sized femoral head to be used to reduce the potential for instability. In May of 2006, I signed on to have a DePuy ASR total hip. It's very interesting to me through this now 16-year saga that at the time I truly was aware of what I had experienced, which was truly at the early 2010, after my hip had been revised and my neurologic issues, my psychiatric issues, and my diastolic heart failure all resolved themselves, as did high frequency hearing loss and damning tinnitus. I had reasonable success in letting it be known through the popular press and even medical drama TV shows that this was a significant issue, but have had extraordinary difficulty in getting the American Academy of Orthopaedic Surgery or the FDA interested in the issue. This kind of came to a penultimate peak about a month ago, where arthroprosthetic cobaltism was the subject of the finale of the very popular Grey's Anatomy TV serial, where their premier senior surgeon, Dr. Weber, decompensates at a medical meeting. Everybody believes he's demented. And until the last minute, where it's also become apparent that he has profound peripheral neuropathy. And the dramatic moment here in the operating room is they're ready to do a sural nerve biopsy when the bipolar, mentally ill resident DeLuca has come to the epiphany that Dr. Weber is suffering from arthroprosthetic cobaltism. So he comes into the OR, knocks over the instrument tray, and recommends that they draw the patient's blood to check a cobalt level rather than proceeding with an operative procedure. And there you can see them handing over the tube, despite spending 4 hours with the writers of Grey's Anatomy. I didn't get it to them that the correct tube is a royal blue top vacutainer, not a light blue top. I think that's the top that's used for a CBC maybe, or electrolytes. But anyway, it's very curious to me that arthroprosthetic cobaltism is well known to almost any American that watches any of the popular serial medical soap operas like Grey's Anatomy, House, New Amsterdam, and The Resident. But the FDA and the American Academy of Orthopaedics are still in complete denial that this problem exists at all, much more that it's common. My story after my total hip, I've got a remarkably resilient physiology. Within 2 months of my arthroscopic chondroarthroplasty on my left hip and my ASR total hip on the right, I did a double century road bike race in Alaska called the Fireweed 200. Did reasonably well with that, and was pretty certain that my ASR hip was a miracle. Then, somewhat surprisingly, about a year after the hip was done, it became progressively painful. Then it became quite noisy over the period of 42 months that the hip was in. It got noisy enough that it could be heard across a relatively busy conference room, particularly if I did a one-legged stand from a full squat, which was something that was quite distressing to the Dubuque representatives that were at the meeting I was hosting in Anchorage, but more concerning about what was happening at the hip, and it did get more painful than the hip was before it was replaced, was that in the interval at 18 months after the hip, while I was at the Sign Nail conference in Richland, Washington, presenting on my experience of starting a sign nail fracture treatment program in Monrovia, Liberia, I had a complete decompensation and basically destroyed a hotel room that I was staying at, writing on the walls and the ceiling that I was being poisoned by cobalt. At that time, I hadn't slept for a week. I had incredible tinnitus, and I had been compulsively checking my blood and urine cobalt levels for the past 6 months. And I knew they were much higher than anybody was admitting would occur in the literature with this particular technology. I'd been discussing indirectly with the design surgeons of the ASR, professors at the Mayo Clinic that I had had up to my meeting in Alaska over the years. They were all reassuring me that they thought cobalt was good for you, couldn't possibly be toxic. And fortunately, what happened near the Hanford reactor when I had my nuclear incident, friends and family came to my assistance, and I was squirreled away and treated with medications and CBT, and that kind of put a lid on it. After 6 weeks, I was able to resume clinical practice, although I kind of felt like a cat on a hot tin roof. And that's where I stayed for about the next year and a half, until the hip became so painful that revision was absolutely mandated. And at that, what was the straw that broke the camel's back neurologically is I developed retinal damage to where I lost a little bit of my visual field. And when I went out after dark, I would see flashing lights in that area, which is a classic sign of retinal deinnervation. And I'd had enough internal medicine and general medical experience to connect the dots. During what was considered to be the manic phase of what was thought to be an atypical presentation of bipolar disorder, I had done some extensive research into cobalt and realized that cobalt has been a recognized cardiac toxin and neurologic toxin since the late 1950s, when it was used to treat anemia, both in adults and in children, as well as multiple case reports of neurologic and cardiac cobalt toxicity related to industrial exposure to cobalt powders. My blood cobalt level at the time I finally caved and had my hip redone was 122 times the industrial exposure threshold in industry of 1 part per billion. So once the hip came out in November of 2009, I had my case report written up in a month. A month later, I revised the only patient that I put in an ASR, who is a geologist, who had much of my same symptoms, fortunately not to the same degree. His experience post-revision was similar to mine, with rapid reversal of the neurologic problems. And at that point, I got quite insistent in chasing down the 6 metal-on-metal hips that I had personally put into patients. Many of those patients were in trouble. All but one now has come to revision surgery. And I was hopeful at that time the problem would be limited to the metal-on-metal technology. Then about 10 years ago, we realized the Stryker rejuvenate hips that utilize a modular chrome cobalt neck were also in trouble. I never did any of those, thank God, but some of my partners at my group practice had. I revised a lot of them, and I talked and got to know to a lot of those patients, and many of them were experiencing the same neurologic toxicity that I had seen to be common in the metal-on-metal patients. And then I was somewhat hopeful that maybe the problem would only occur in the metal-on-plastic hips like the rejuvenate. And unfortunately have found that the problem is generalized pretty much to any modular chrome cobalt component, regardless of articular couple. The main difference is the perfect storm like I had of the ASR suboptimally positioned with edge loading and catastrophic runaway wear. Patients might get symptoms within months, whereas with a metal on plastic hip with a suboptimally designed taper like Zimmer's 1214 tapers, articulating on conventional or cross-linked polyethylene, particularly with the larger head sizes like a 36 and bigger, places increased stress on the taper. Although unfortunately, I've never really gravitated to using large heads. Zimmer chrome cobalt heads on an ML taper stem was kind of my go-to for many years. And I'm routinely screening my Zimmer hips now. And at 10 years out, about half of those patients are in trouble with elevated cobalt levels. And most of the patients with elevated cobalt levels have some degree of the neurologic symptomatology as measured by a clinical point scoring tool that we've developed. To put this in the context of North America, there's probably about 12 million 20 million North Americans that have some chrome cobalt arthroprosthetic component. So in terms of number at risk, that equals about 57 Hiroshimas. And clearly it's not as spectacular as dropping a nuclear bomb, but the numbers are similar. It's just a much more indolent problem that evolves over time. So after case, meaning 2 cases, myself and my geologist patient with an ASR hip, we initially published in the State Epidemiology Bulletin, trying to raise awareness that this was a potential problem in patients with metal on metal articulations. And we were on the pathway to get this published in the Morbidity and Mortality Weekly Report that's done by the Center for Disease Control, which would have raised national awareness of this problem. And I first became aware that something was wrong in Denmark when the FDA intervened and would not allow the CDC to publish our report, an abbreviated version, in the MMWR. And, basically the FDA told the CDC to bugger off because this was their personal fiefdom. I've later come to realize with my multiple communications with the FDA that, pardon my language, they're basically industry's whore. And they are much more concerned about the health of the arthroprosthetic industry than they are in the health of patients. So we did persist, and we got the 2 case reports published in JBJS online in October and in print in December of 2010. It was difficult to get Journal of Bone and Joint to publish it. The section editor for arthroprosthetics was a Depew consultant. And clearly they were trying to kill the paper by a death by 1,000 cuts. I actually did an in-run around the section editor, went directly to the editor-in-chief, who is a pediatric orthopedist without any sort of economic conflict of interest. He seemed somewhat aghast that they had delayed publication. I had not yet disclosed to JBJS that I was one of the 2 cases. He said, that's no problem. We just put an asterisk by your name and put that in the report. And then he said, so you're not alarmed. Be aware that the American Academy of Orthopedic Surgery is going to release a commission commentary on your case report, simultaneous with publication of the case report. And the presidential line of the American Academy of Orthopedic Surgery at that time, president was John Callahan, first vice president was Dan Barry. Two of them are long-term DePuy consultants, both compensated in the millions of dollars over many years. Third vice president was Josh Jacobs, very respected bioengineer as well as orthopedic surgeon, much less conflicted than either Callahan and Barry, but his research has been extensively supported by industry over the years. And he had many joint publications with Thomas Schmalzried, the design surgeon for the ASR, the implant that poisoned me and was the topic of the case report. The popular press took an interest in this story fairly early. Barry Meyer published a 13-part series on it in the New York Times. Actually, one of them featuring my second case holding his ASR hip. In 2011, it became topic of a House episode where the diagnostic ultimate moment is House makes the diagnosis by operating on Cuddy's mother's hip without anesthetic at bedside, revealing all the metallosis in the hip. And when the residents, his little posse of acolytes that follow him along, look at that and see all the black stuff, one of them says, "Is that necrosis?" And House pithily replies, "Not necrosis, metallosis." And of course, Cuddy's mother-in-law, who's actually played by Candice Bergman, makes a miraculous instant recovery once the evil humors are released by House's knife. I don't recommend that technique. The whole House episode was the child of John Sotos, who was one of my undergraduate classmates and is a distinguished academician who writes on obscure diagnoses and a book called Zebra Cards about atypical presentations of common problems and typical presentations of uncommon problems, and is also a Lincoln Scholar in addition to being the chief flight surgeon for the National Guard, state of California. John and I published a paper concerned that we are aware a lot of high demand Air Force pilots had metal on metal hips done. We were concerned that if they had elevated cobalt levels, it might be affecting their fitness to be aviators, and continued to publish on the topic. Got invited to be a speaker at the Safe Patient Project in New York City at the end of 2013. Subject of a Consumer Reports article on poorly vetted medical devices. And I just kind of gone down this rabbit hole of patient advocacy and public advocacy for better regulation of these devices, which has really got me into the company of some very interesting, accomplished individuals. And the upper left is Kevin Kavanaugh, who's a retired ear, nose, and throat surgeon, MPH, very much a thorn in industry side concerning infection control and poor public health policy. And he's very much involved in rating the United States response to the COVID-19 problem, which we have not done very well in the United States in dealing with that problem, considering we're the wealthiest country on the face of the earth. Upper right is Dr. Jocelyn Elders, who is Surgeon General under Clinton until she got into trouble and had to resign, but she suggested that sex education should be taught in the regular curriculum in our public schools. And At the bottom middle is Madrice Tomes. She's mainly a data person who has formed a company looking at taking the FDA MOD database and getting some meaningful data out of it independently. It's completely worthless in the hands of the FDA. And on the bottom right is John James. I co-authored a chapter in his book on the hip issues. Jeannie Lenzer was on the lower left. I co-authored a chapter on her in her book. Gilbert Welch, oddly enough, when I was in the public health service, I actually worked with him in Bethel, Alaska, in a small rural hospital. And that's John James' book on the right. But I've learned being a whistleblower at Cassandra is not necessarily a popular role. Most of us meet a tragic end. Fortunately, I seem to be beating the odds. But my interest in the hip cobalt problems, which appear to be quite common, nearly resulted in my loss of privileges at the major tertiary hospital I work at. Resulted in my partners at my group practice telling me that, Steve, if you're going to go jousting at windmills, particularly huge companies with huge departments of lawyers like Johnson & Johnson, maybe you ought to start your own clinic, which I did 5 years ago. That actually turned out to be an opportunity. There's a new building I moved into, had an imaging center downstairs. And there I met this guy on the right who's a dual boarded nuke med diagnostic radiologist who had done very notable work on fusing PET brain scans with CT scans without dedicated machines. Also a pioneer in PET bone imaging, who I guess just had a wild hair up his behind and decided to move to Alaska. And this brain scan is our index patient, a lady with bilateral DePuy pinnacle metal on metal hips, who I knew very well, did not have her op reports, and had done a total shoulder on her, which was a Bigliotti Flatow Zimmer shoulder modular. She also had bilateral total knees. So we later came up with a prosthetic risk score. You get 3 points for having a metal on metal. You get 1 point for each cobalt part that you have. She would have a prosthetic risk score. Each of her, since her pinnacles were modular, she gets 3 points in each hip just for the components, another 3 points for each hip for having a metal on metal. So that's 9 points just for the hips. She gets 2 points for the knees because she has chrome cobalt femoral components in both knees. So we're up to 11. And then her shoulder, she had total shoulder, but it's got a chrome cobalt stem and a chrome cobalt head. So she gets 2 points for that. So she's got a pretty high prosthetic risk score. She had a very high cobalt symptom inventory score that I'll get to later, having developed peripheral neuropathy, severe fatigue, mood disorder, chronic pain, sleep disorder. She did not have cardiomyopathy. And the bottom, she's the first patient we did FDG PET brain scan on, and she's got generalized blue brain. With this particular imaging modality software, it shows hypometabolic brain as being blue, polar colors. And blue is bad. It means the brain is not utilizing glucose at its accustomed rate. And we've come along with that technology with other software packages that are much more granular. This is one of her hips. Again, cobalt chrome stem, chrome cobalt head, chrome cobalt acetabular liner. She's got corrosion at every interface, plus the scratching and wear of the bearing. I don't think there's any case reports yet published of maybe one of acetabular side taper corrosion, but I'm seeing that quite commonly on the modular metal on metals. I was pretty cocky and content that I only put in 6 metal on metals and I never used the rejuvenates. And, that's the way orthopedic surgery is. As soon as you think you know something and you're good, you get humbled. And what humbled me is suddenly I had a slew of my own patients with very typical modular single piece stems, not modular necks, both Stryker and Zimmer. The Stryker V40 taper is absolutely terrible for this, but Zimmer's 1214 taper is almost equally as problematic. These patients commonly get treminosis. They get elevated cobalt levels. They get all the neurologic toxicity that I've seen with the metal on metal hips. It just takes them longer to get into trouble. This is, I think that's a rejuvenate case on the left, and on the right, I think that's a Zimmer 1214 taper. But I've seen so much of this, I'm almost surprised when a patient comes in and they've had a hip that's been in for 10 plus years when they don't have it, and I get their urine cobalt level back and it's less than 1 part per billion. This is kind of typical scenario. One very concerning thing is that I think the older people are actually more susceptible to this and get into trouble quicker. I've got 4 patients that have developed lymphomas coincident with their elevated cobalt levels. I know the literature is mixed on that. This guy had a particularly convincing case, as one of my other patients did, where the lymph node abnormalities were, right around the prosthetic joint that was in trouble. This is a rather sobering recent realization, is that chrome cobalt cemented stems can develop this problem at the cement stem interface, and in absolutely spectacular fashion. And this has now been described in multiple polished chrome cobalt stems, the ones that are a force open design, polished deliberately to allow some micromotion. It's actually noted to occur in stainless steel stems like the Exeter, but it appears generally to be without consequence when it occurs with a stainless steel stem. But when it occurs with a polished chrome cobalt stem like the Zimmer Heritage, which I was very fond of early in my career, it can eventually result in an adverse reaction to metal debris at the hip. These, in my experience, have not been loose at all when I've come to take them out. As you can see in this case, I had to resort to an extended trochanteric osteotomy. But it's interesting, this got me thinking, is why the hell did we ever start using chrome cobalt? And the interesting thing is, really for no good reason whatsoever. There are some sporadic case reports of fractures of Charnley's low friction arthroplasty, which was successfully dealt with by making the stem more robust. But I was quite amazed when I went back and reviewed the literature, how little work had been done to look at the fundamental biocompatibility of chrome cobalt in the human body. This is another case of one of my heritages. Granted, this one had been in almost 30 years, and the patient has only gotten into trouble within the last couple of years. some people would consider that to be a success. She was developing some lysis at the cement mantle, but the stem was fairly soundly fixed. I was able to get this one out without a trochanteric osteotomy. But I don't believe we should ever be putting stuff into the human body that has the potential to eventually poison the patient. I just don't think that's good medicine. I'm seeing this in shoulders, I'm seeing it in knees, not as commonly, probably related to the forces across the joint. This lady had a complex presentation with a lot of immune symptoms. There's a syndrome called Asia syndrome or Schoenfeld syndrome that she met the criteria for. She was confounded, but she also has bilateral total knees with chrome cobalt components. I serially aspirated all her joints and was able to prove that her elevated cobalt levels were from her shoulder hemiarthroplasty, which was a DePuy implant with a titanium stem with a cobalt head. And she improved after revision surgery and her levels went down. This is a more recent case, Zimmer connective, 32 millimeter chrome cobalt head, not particularly large. This lady had significant symptoms at the hip, had a significant clinical and histopathologic adverse reaction to metal debris, but a very severe related immune syndrome delineated in the text of the slide. So what I've learned now after seeing hundreds of cases is there's a common clinical syndrome associated with elevated blood and urine cobalt levels. The most common things we see are fatigue, cognitive decline, disordered mood, peripheral neuropathy, and cranial neuropathies, immune syndromes, cardiomyopathies. Many, but not all of these patients have symptoms at the hip and clinically have an adverse reaction to metal debris, but not all do. The pathophysiology of the systemic problem is cobalt's a metabolic toxin. It poisons the mitochondria. And to add insult to injury, people can also have an immune related reaction to it. I think the people who react in immune fashion are much more likely to get the full-blown syndrome at lower cobalt levels as well. We've learned the FDG PET brain scans are very sensitive and probably diagnostic for the problem. And we're routinely doing those in any patient where we need to confirm the diagnosis, who have the clinical symptoms and have a urine cobalt greater than 1 or a blood cobalt level of greater than 0.4 parts per billion. What I've learned is any patient with a chrome cobalt arthroprosthetic component is at risk. Certainly the patients that have multiple arthroplasties, multiple parts, multiple taper junctions and metal on metals are at the higher risk. And certainly there's a very strong design issue. The hip resurfacings are generally much better than the modular hip replacements because they don't have the taper junctions. But almost every patient I see with a hip resurfacing greater than 10 years out is in trouble. And they all have urine cobalt levels greater than 1 part per billion. So where we are now, this is dated material. The last formal review we did of IRB approved review of our data, 241 patients screened with an at-risk joint. More than half had a urine cobalt greater than 1. 69 of the cobalt positive patients we got FDG PET brain scans on, they were all significantly abnormal. This is the incidence of symptoms in the cobalt positive patients. And in every instance, statistically more common in the cobalt positive patients than the patients that were cobalt negative. This scatter plot, the red data points are the metal on metals. The blue squares are the metal on plastics or the hemiarthroplasties. And certainly the metal on metal hips are more likely to have higher cobalt levels. The Y value is the product of their urine cobalt level multiplied by the years that the joint had been in. Many of these patients are confounded by having multiple total joints. This is excluding the metal on metals. These are just hips. And what this shows you, the blue diamonds are patients that have hips that have tapers that I've rarely seen problems with. These are the archaic DePuy 14-16 tapers, DePuy's 12-14 taper when it's not used with a metal on metal articulation. The old osteonic C taper, I've never seen a problem with. The red squares are all my Zimmer 12-14s and my Stryker V40s, which get in about half of them are in trouble. And there's no particular rhyme or reason, head size, whatnot, year placed in for who gets into trouble and who doesn't. I did most of these hips. I'm compulsive. I'm not an MIS surgeon. Those heads are all placed clean. They're all impacted 3 times with progressively forceful blows. I absolutely follow the book. And I just cannot figure out why half the patients get into trouble and half don't. But there's an involving literature written by by Langton, blocking on his first name out of the UK, which suggests this is probably a tolerance issue. The V40, I think, is just crap. It's just underpowered to be used with a cobalt head. With the Zimmers, it may be that the taper mismatch between the head bore and the trunnion is too variable and often out of tolerances to the point that patients develop this problem. Some other authors have found, I think it is more common with the larger head sizes. Larger head sizes definitely place more forces on the taper. But again, I rarely use anything larger than a 32. So most of these patients that are in trouble have got 32 millimeter heads. Few have 36s. Interestingly, I've got a small cohort of patients with 38 millimeter Zimmer heads, which were spec'd by Sulzer. Those were inherited from the Metasol line. I was using them metal on plastic with a Sulzer heritage cup that Zimmer had acquired called the Converge, and none of those patients have developed taper corrosion. So again, I think a lot of the taper issues are design and related to tolerances. My experience with my patients that are sick with cobalt systemically is they tend to improve if you revise them and get rid of the cobalt. N-acetylcysteine also seems to be effective. I put a lot of my patients on N-acetylcysteine, ones that are too sick to be revised, ones that don't have symptoms at the hip, ones that have minor neurologic symptoms, and we wait and see. I'm not an aggressive surgeon. I prefer these patients get better without having to undergo a high-risk revision. And the repeat brain scan patients tend to get better as well. When we try to correlate the brain scan patients either to their symptom score or to their cobalt levels, they seem to sort into different groups, which seem to suggest there's significant host factors to the systemic toxicity. And this makes sense because there's a big difference in cobalt binding from individual to individual. And there's even a difference in cell transport. This is just a guideline about cobalt levels. Blood cobalt of 0.4, a urine cobalt of 1 represents 95th percentile of a population that's not exposed to cobalt. So that's how we determine those break-offs. The periprosthetic complications of chrome cobalt metallosis are well described. both with the metal on metal hips and the patients with metal on plastic hips with taper corrosion. I think the systemic issues are best described as a toxic progeria. It's like patients get hit by the old age truck 10 or 15 or 20 years prematurely. We do see a significant correlation of this Cobaltism symptom inventory score with the product of their urine cobalt and the years hips have been in. Couple cases. This was a case report we published in JBJS. A pilot here in Alaska lost his livelihood because of progressive Parkinson's. Point, he had a brain stimulator, maximal medical therapy, and his Parkinson's all but went away when we revised his metal on metal Magnum Biomet hips. He never returned to flying because he has a deep brain stimulator that excludes him from getting his commercial pilot's ticket back. This was a nurse who worked in the same hospital as a surgeon. She would bump into the surgeon, "Oh, I love my hip's fine." In the meantime, she's developing cognitive decline and a tremor to the point where she can't start IVs. She loses her job, and we don't figure things out until she shows up in clinic. And her surgeon had been resistant to routinely bringing his metal on metal patients in. And getting their cobalt levels checked was one of the reasons I'm no longer working at that clinic. But one of the PAs who saw this lady when she came in with her back thrown out knew I'd been squeaking about getting cobalt levels, got a blood cobalt, it was 63. Her hip got revised, her symptoms all but went away. Again, this is our repeat brain scan post-revision. The amazing thing to me is that I didn't figure this out. This was described by Dr. Jones, 1975 in Journal of Bone and Joint Surgery, series of patients with McKee-Ferraz. He described both the periprosthetic complication and he speculated about the systemic toxicity, and he actually measured increased levels of cobalt, I believe, in the heart, liver, and brain at post-mortem in some of his patients that were deceased. This is a 1,000-page text about cobalt and its toxicity, which was commissioned by the US government, copyrighted in 1981. How did we get here? We don't test this stuff for shit. Any company can get anything on the market shown that is somehow related to something that was put into people before we even had regulations. This is the paper by Stephen Graves, the Total Joint Registrar in Australia, describing how the whole debacle of the metal on metal hip. In the United States, we have a real problem with conflict of interest, and I've put in 15 submissions to the annual meeting at the American Academy of Orthopaedic Surgeons. All but 2 have been declined. Finally, in 2018, they took 2 of my poster submissions. But there have been reputable organizations looking into these complications. This is a team at Dartmouth Biomedical Engineering Center who I've collaborated with since 1992. About half of their metal on metal explants that they described were my cases, revision cases. And this is the 2 posters that we got accepted at the American Academy meeting in New Orleans in 2018. We were in the nosebleed section of the stadium. We got some traffic by the posters. Dr. Schmalzried was still chairing the Hip Society session on complications, metallosis complications. And as you might imagine, he does not believe it's a common problem. I already mentioned Madrice and her device events, which has taken data out of the mod and actually gotten something useful out of it. These are a bunch of ladies I actually met when I went to DC. Most of these ladies got this notorious Escher tubal ligation device, which has got all sorts of crap in it. including, doesn't have cobalt in it, it's got gold in it, a bunch of other metals, polyethylene tetraphthalate, whatever the hell that is. But a lot of these women develop much the same systemic problems as my cobalt hip patients. And this fits into this syndrome known as Asia syndrome or Schoenfeld syndrome. I think we did a very solid paper on the brain imaging that got published in a European journal at the end of last year. This is a paper that is undergoing peer review now, concentrates more on how common it is in the clinical presentation and the correlation of urine cobalt, joint fluid cobalt to urine cobalt. There's a strong correlation there. Strong correlation between urine cobalt and blood cobalt. Significant strong correlation between the prosthetic risk score and the product of urine cobalt in the years of implantation. Statistically significant, strong association between the Cobaltism symptom inventory score and the degree of cobalt exposure. So that's a presentation. The bottom line from my experience as a patient, researcher, surgeon is no one should put chrome cobalt into the human body. It's a known toxic material. Certainly you get away with it if the design is very good. But in terms of the metal on metal hips, I don't see anyone who isn't in trouble if the joint has been in long enough. And happy to entertain anybody's questions.
Thank you, Prof. Tower, for that brilliant presentation. And it was very enlightening to everyone. There were a couple of questions that have come to me. Someone asked, what is the significance of metal ion hypersensitivity that we see normally in people? For example, sensitivity.
I think it's a significant problem. That was the specific topic of the expert panel I testified before in Washington, D.C. I think the immune complication, the Schoenfeld syndrome or the Asia syndrome, in conjunction with either the blood testing for an immune sensitivity to the metals, which is available, I think, out of a couple of labs. I'm not sure what the availability is outside the United States, but there's one survey by Orthopaedic Analysis is the company, done out of Rush in Chicago. And there's, of course, the traditional skin testing. I think it's a real thing. You know, I think if you got a patient that tells you they got a nickel allergy, you know, if I got a patient that has a compelling story for nickel allergy, I won't put an Exeter in them, which is stainless steel. And that's my go-to prosthetic for 90% of my patients. I think that's a very well proven implant. Those patients get a titanium stem and a ceramic head and a cross-linked polyethylene liner. There's a lot of known cross-sensitivity between nickel and cobalt. And I would say of the patients in my experience that are in trouble, they have elevated cobalt and they have symptoms, they have clinically, they have cobaltism, they have the abnormal brain scan. 10 to 15% of those patients also appear to have an immune component. So I think it definitely exists, but I think it's a minority of patients. And I think that there's a misunderstanding among orthopedic surgeons that the hypersensitivity is the only issue. And the only patients that get into trouble are the patients that are hypersensitive. And that's not my experience. And in fact, I had both the patch testing personally and I had the orthopedic analysis, and I had no sensitivity to any of the orthopedic materials tested. In terms of the neurologic toxicity, I think if your levels get high enough, anybody will get it. And, you know, the number of case reports of fatality from elevated cobalt levels due to multi-organ failure, mainly cardiomyopathy, is now up around 10. I think anytime you see a case report, you know, you can multiply that by thousands as far as how many are really out there. And nobody, except for best I can figure, Steve Tower in Anchorage, Alaska, wants to study this in the United States. Because you can imagine if you're a high volume arthroprosthetic surgeon, you put in thousands of these things. Do you want to know that you may have poisoned hundreds of your patients? You don't want to know that. Revisions are a pain in the ass. You're running a busy clinic, patient comes into you, they have these symptoms, and you start telling them, well, I think you might be cobalt poisoned. I think we need to send you across the street to get a urine cobalt level. You know, a typical orthopedic 5-minute visit has suddenly turned into an hour. You know, what's that going to do to the schedule of a guy like Tom Schmalzried, who probably does 20 joint replacements a week or more? That's going to blow his schedule out the door. He doesn't want to believe this. And if he's got 10 PAs and residents working for him, do they want to go to the boss and say, oh, Dr. Schmalzried, all your hip resurfacing patients seem to be sick? You know, I mean, that's a good way to get fired.
Okay, Prof. Thank you for that reply. And the other question is there still risk of having metal and cobalt toxicity? Because we still do a lot of cobalt chromes, right?
Yeah, I don't. Because my heritages are going bad at 15 years. And more than half of my Zimmer 1214s and more than half of my Stryker V40s are in trouble at 10 years. And my main workaround to that, particularly from a cost containment perspective, I mean, that's the reason. I mean, when 1992, I was doing hybrids on almost everybody. I was cementing Zimmer heritages, which, you know, I'm sad that they're getting into trouble at 15 years, but they hadn't get in trouble nearly as quick as a lot of the taper corrosion cases. These modular necks are terrible. There's this company called Microport that got Wright Medical's Profemur Z, and they're just like the Rejuvenants. They corrode at either end of that modular chrome cobalt neck, and not many people are publishing on that. I'm not sure there's even a case report of the Microports, but I've got a handful of them, and they're just as bad as the Rejuvenants. And I get emails from all over the country because the small incisions in the anteriors are popular. The modular necks are still popular with some surgeons in the United States. Different brands that aren't known to be a problem. But I see they're a problem even if they're used with a ceramic head, because they still corrode. You still get mechanically assisted crevice corrosion occurring at the trunnion of the chrome cobalt trunnion and the bore of the ceramic head. Not to mention you're getting the corrosion at the other end of the modular neck, which is more problematic because of the forces involved. But, you know, what I told the FDA is this is a public health travesty. You guys are asleep at the switch, you know, and you won't even listen to anybody. You won't put anybody on your panels that's knowledgeable, that's published on it, and certainly not going to put anybody on a panel for the FDA that's been critical of the FDA.
Thank you so much, Prof. What do you think about trunnienosis? Is the same, similar phenomenon?
Yeah, trunnienosis is, you know, most of my cases a small, my experience now is, 80% trunniinosis, taper corrosion, and, the balance is metal on metal. So numbers wise, the trunniinosis or any taper corrosion is, and I kind of glossed over the prosthetic risk score. It's actually, you get 3 points for metal on metal. You get 2 points if it's metal on bone, because the shoulder hemis and the hip hemis seem to have greater risk of wear of the head versus wear of chrome cobalt by plastic. Then you get a point for every taper junction, and then you get a point for every individual chrome cobalt component. But that score holds up really well. It's very predictive of what the patient's cobalt level is going to be. But I've got a fair number of patients where, they've got 2 shoulders, 2 knees, and 2 hips. And, they've been in for a while. And almost all those patients are in trouble. So I won't put chrome, I'm not putting chrome cobalt knees in. I'm using alternative, there's a couple of alternative materials you can use in the knee that are well proven. Oxinium is one. I don't really like the titanium alloy as a bearing surface, just because we've had such a mixed experience with that over the years. So, I don't like pitching any one brand of anything. But in the knee, the only thing I'll use is oxinium, because I think it's the only thing that's been around long enough that's proven to be a reasonable alternative. But even oxinium's got significant issues, because it's, you know what an Eskimo pie is? It's an ice cream bar.
Yeah.
Eskimo pie is an ice cream bar.
Yes.
Well, that's like oxinium. It's got a very hard surface, but it's soft on the inside. So if you get that into a 3-body wear circumstance, you can eat the softer material alive. But the oxinium is, the base metal is zirconia. So it's in the same periodic table column as titanium. And it seems to be quite resistant to corrosion. So, the worst cases of systemic poisoning from total joints have been revision arthroplasty after fractured ceramic. Those are the patients that have blood cobalt levels around 1,000 who die. And there it's because you get retained ceramic fragments get embedded in the polyethylene revision liner, and they eat the chrome cobalt head alive. But my awareness of how common this problem is not only comes from my practice and review of my own patients that are high risk, but since I published my first paper, every week I get another email or a phone call, of someone who's in a hospital somewhere and they're in heart failure. And they've been sitting there and no one's been able to figure out. And somebody usually watches one of these soap opera medical dramas, looks into it, my name comes up and they call me. They said, well, does your mom have a joint replacement? Oh yeah, she had one. It just got revised 6 months ago. And you follow the story, and some numbskull revised a fractured ceramic with a cobalt head. And the lady is deaf, blind, peripherally neuropathic, and she's been sitting in a hospital on a unit for 2 weeks, and no one's been able to figure it out. We got to get smarter than that as orthopedic surgeons.
So what do you think are the options other than cobalt chrome? For example, you said zirconium, oxidized zirconium, oxinium.
Yeah, oxinium is what I use in the knee. My go-to hip is the Exeter, stainless steel stem, stainless steel head. You can't beat the data. I mean, look at it in any total joint registry. It beats everything in all categories. The only time I get cherry about putting an Exeter in is if the patient has such good bone that I know I'm going to work harder than I want to work to broach up the canal to make room for the cement. So, you know, a real Dore fluted. Sometimes it's just political because the patient comes in and they think they're well informed. And I talk about putting a cemented hip design in them that's been around for 50 years. And, you know, they've just been online and realized that the best hip in the world is made out of kryptonite and you put it in through the navel. So, you know, that's probably something that you guys don't have to deal with so much, and we do here in the free market. But yeah, you know, hip, stainless steel, Exeter, Bernie Morey, you know, revered professor at Mayo Clinic, came up to my meeting I do in Alaska. Oh, he came up about 10 years, 12 years ago before I had my, it's right when I was getting sick with my ASR. He gave a great lecture. He says, Jesus, you know, you got anybody over the age of 70, cement both sides. And that was like, we're sitting there going, cement the socket? Who's ever cemented a socket? Nobody cements the socket. Well, I've been cementing sockets in revision work, doing slope procedures. So it didn't seem completely crazy. So, you know, 10, 15 years ago, I started cementing sockets on my older patients. It works great. They have less instability because you get nice and flush with the rim of the socket. They don't impinge. It's a beautiful technology. And now you can get cross-linked cemented liners. Yeah, not liners, but monoblock polyethylene. So it drives me crazy because so much of the bad stuff we've done has just been driven by marketing, and it's not supported by any science. And then you produce science saying that it's all screwed up, and they try to hold you to a much higher level of evidence to prove that than ever was demanded to get the stuff put on the market in the first place, which was all anecdotal rock star surgeons getting paid millions of dollars by industry who have these very fit young patients coming to them. And then you show videos of them barefoot water skiing, you know, a month after they have the operation. And, you know, all you have to do to get busy as an American surgeon is just say you're the first guy on the block putting the kryptonite hip in through the navel. And, you know, people will travel halfway around the world to have that done.
Thank you, Prof. I think no more questions from the audience. It was very, very enlightening from your side. Thank you for that brilliant lecture. You've told your own experience, and that's the biggest thing. I mean, someone who has gone through it, experienced it, published it, that is simply amazing. Thank you, Professor, for joining.
Yeah, and thank you for hosting me. It's really fun.
Thank you very much, Prof. And we look forward for more from your side, and we can talk on different topics.
Yeah. How often do you do this, and how do I sign up so I can watch whenever you do one?
Yeah, I'll send you the link, Prof.
Yeah, send me